Welcome to the Dr. Izzy's Medical Podcast channel.
Porphyrias. Porphyrias are a group of liver disorders in which substances called porphyrins build up in the body, negatively affecting the skin or nervous system. The types that affect the nervous system are also known as acute porphyria, as symptoms are rapid in onset and short in duration. Symptoms of an attack include abdominal pain, chest pain, vomiting, confusion, constipation, fever, high blood pressure, and high heart rate. The attacks usually last for days to weeks. Complications may include paralysis, low blood sodium levels, and seizures. Attacks may be triggered by alcohol, smoking, hormonal changes, fasting, stress, or certain medications. If the skin is affected, blisters or itching may occur with sunlight exposure. Most types of porphyria are inherited from one or both of a person's parents and are due to a mutation in one of the genes that make heme. They may be inherited in an autosomal dominant, autosomal recessive, or X-linked dominant manner. One type, Porphyria cutanea tarda, may also be due to increased iron in the liver, hepatitis C, alcohol, or HIV/AIDS. The underlying mechanism results in a decrease in the amount of heme produced and a buildup of substances involved in making heme. Porphyrias may also be classified by whether the liver or bone marrow is affected. Diagnosis is typically made by blood, urine, and stool tests. Genetic testing may be done to determine the specific mutation. Treatment depends on the type of porphyria and the person's symptoms. Treatment of porphyria of the skin generally involves the avoidance of sunlight, while treatment for acute porphyria may involve giving intravenous heme or a glucose solution. Rarely, a liver transplant may be carried out. Acute intermittent porphyria. Acute intermittent porphyria is a rare metabolic disorder affecting the production of heme resulting from a deficiency of the porphobilinogen deaminase. It is the most common of the acute porphyrias. Signs and symptoms. The clinical presentation of acute intermittent porphyria is highly variable and nonspecific. The patients are typically asymptomatic, with most gene carriers having no family history because the condition had remained latent for several generations. The syndrome marked by acute attacks affects only 10% of gene carriers. Like other porphyrias, acute intermittent porphyria is more likely to present in women. A distinguishing feature of acute intermittent porphyria that separates it from other porphyrias is the absence of photosensitive cutaneous symptoms that occur in addition to acute attacks. Acute attacks. Acute intermittent porphyria is one of the 4 porphyrias that presents as an acute attack. 90% of affected individuals never experience an acute attack and are asymptomatic, while an estimated 5% of affected individuals experience repeat attacks. Attacks are most common in young adult women and are rare before puberty or after menopause. Severe acute attacks may require hospitalization. Patients usually experience symptoms in attacks that last from several hours to a few days. Between attacks, patients are asymptomatic. The most frequent presenting symptoms are abdominal pain and tachycardia. The abdominal pain is typically severe, colicky, poorly localized, and often associated with pain in back and legs. Patients may also present with vomiting and constipation, but diarrhea is unusual. The onset of back and leg pain is characterized by severe pain and stiffness in back and thighs followed by loss of tendon reflexes and paralysis. Psychiatric symptoms are present, such as paranoid schizophrenia-like features but rarely psychosis and hallucinations. The acute attacks classically present with dark red photosensitive urine, but this is a non-specific symptom. Physical examination often shows no abnormalities. Diagnosis. The initial diagnosis of acute porphyria is confirmed by urinalysis, including the common method, the Watson-Schwartz test. Elevated urine porphobilinogen confirms diagnosis of acute intermittent porphyria, hereditary copper porphyria, or variegate porphyria. A positive test should be indicated with an increase of 5 times normal, not just a slight increase which can occur with dehydration. To distinguish between acute intermittent porphyria from hereditary copper porphyria and variegate porphyria, fecal porphyrin levels are normal in acute intermittent porphyria but elevated in hereditary copper porphyria and variegate porphyria. Rapid, accurate diagnosis is important. Delays in diagnosis may result in permanent neurological damage or death. Hyponatremia is the most common electrolyte abnormality during acute attacks, occurring in 40% of patients and presenting as syndrome of inappropriate secretion of antidiuretic hormone. Hypomagnesemia is also common. There are no pathognomonic signs or symptoms. The most common identified triggers for acute attacks are medications, weight loss diets, and surgery. Many medications have been associated with acute intermittent porphyria including antibiotics, hormonal contraceptives, seizure medications, anesthetics, and HIV treatment drugs. Treatment. If drugs have caused the attack, discontinuing the offending substances is essential. A high carbohydrate, 10% glucose, infusion is recommended, which may aid in recovery. Hemeton and hemarginate is the treatment of choice during an acute attack. Heme is not a curative treatment, but can shorten attacks and reduce the intensity of an attack. Side effects are rare but can be serious. Pain is extremely severe and almost always requires the use of opiates to reduce it to tolerable levels. Pain should be treated as early as medically possible due to its severity. Nausea can be severe. It may respond to phenothiazine drugs but is sometimes intractable. Hot water baths or showers may lessen nausea temporarily, but can present a risk of burns or falls. Seizures often accompany this disease. Most seizure medications exacerbate this condition due to their induction of cytochrome P450 enzymes. Treatment can be problematic. Barbiturates and primidone must be avoided as they commonly precipitate symptoms. Some benzodiazepines are safe, and, when used in conjunction with newer anti-seizure medications such as gabapentin, offer a possible regimen for seizure control.
Thank you for listening Dr. Izzy's Medical Podcast Series. If you want to support this project, please subscribe the channel and like this video. Thank you.